Good afternoon, everyone, and thank you for joining us for today's webinar, Strategies for Success, Navigating Access to Electronic Medical Records. We're so pleased that you could all join us as we have what I'm sure will be an informative presentation for you all today. Before we get started, my name is Sienna Fenton, Program Manager here at the Alliance, and I'd like to take the next few minutes just reviewing a few housekeeping items. As always, it is highly recommended that you access our webinars using the Chrome browser in order to ensure optimal visual and audio experience. If you're already using Chrome and are still experiencing any issues, please try connecting to the webinar using the phone number that was provided in your confirmation email. Now, to those of you who may be joining us for the very first time on this platform, please take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat will be used to pose your questions to our speakers. So if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation has concluded, we'll have some time for our presenters to address as many of your questions as time allows. Now, for anyone that may be interested in our upcoming webinars, registration is currently open for our Brain Death Declaration webinar, which will be presented from a physician's perspective. We'll be hosting that on November 13th at 2 p.m. Eastern. Registration is also open for our very last transplant webinar of the year, Seeing the Future, Medical, Ethical, and Financial Considerations of Hepatitis C Transplant. So be sure to join us for that on November 21st at 3 p.m. Eastern. For more information on these webinars or to register, please visit our website at organdonationalliance.org. Now, for anyone interested in obtaining continuing education credits, we are offering one set-C credit and one nursing contact hour for this webinar. Please note, we do also offer a certificate of attendance for anyone that's seeking CEs that are not available. Everyone joining us today is eligible to claim either of these credits or certificates. Prior to receiving your certificate, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, as many of you are, please be sure to get the evaluation email from your group lead. As a friendly reminder, for nursing, you'll have 14 calendar days to claim your credits, and for Step C, you'll have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Nikki Ehrenberg, Nurse Supervisor at UCSF Medical Center. Nikki, thank you so much for joining us. It's a pleasure to have you. And at this point, I'll go ahead and turn it over to you to introduce our presenters.
Perfect. Thank you so much. So I'd like to introduce Elle Tallent, and she has been in the OPO industry for 10 years, starting in the support call center for LifeLink Foundation to working at 3 different OPOs within the role as a hospital development liaison. Excuse me. She then moved to an IT role at Donor Network West as our Identity Access Management Analyst. This allowed Elle to broaden her scope of OPO experiences. Elle is able to connect with both hospital champions and hospital ID departments to speak the same language in order to obtain the correct level of EMR access to hospital systems. Elle is currently the EMR specialist of LifeLink of Georgia and Florida, and she's actively establishing EMR access in Georgia for the top 80% donor hospitals with on-site and remote access capability. In addition, I'd like to introduce Robert Glazner. Robert has been in the organ and tissue donation industry for over 12 years as a data intelligence manager. He has spent over 9 years with the Donor Network of Arizona, managing staff responsibilities for EMR access, death record review, and hospital reporting and analytics. Robbie is currently working on a Doctor of Business Administration and Services as Vice Chair of the Data and Information Management Council of AOPO. He has participated in research through the Organ Donation Council of AOPO and the UNOS Region 5 Research Committee. And I'd like to say thank you to them both for taking their time today to come together and provide us with some additional information.
Thank you, Nikki, for that introduction. Like she said, I'm currently the EMR Document Control Specialist for LifeLink of Georgia and LifeLink of Florida. I've previously worked as an Identity Access Analyst for Donor Network West, and I began my career in hospital development with more than 7 years of experience working with LifeLink of Georgia, LifeLink of Florida, and Donor Network West. By the end of this webinar, you will take away fundamentals to build your EMR roadmap to success. We will be reviewing and discussing some of the following: who should be in internal and external strategic EMR meetings, where LifeLink was and where we are now with our EMR access, meeting with hospitals and our experience, and expecting the unexpected, what hospitals might ask for that you may or may not need to provide, and our ongoing excesses, maintaining motivation with hospitals and your staff. I will provide you with a dual perspective from working within two different OPO service areas with very different hospital landscapes. The donor service areas that I work within have a mix of rural and urban hospitals. There are also large system-based hospital facilities, but most hospitals remain independent. This is the service area of LifeLink of Florida and Georgia. Our current focus for EMR Access has been within the service areas of our OPOs in Florida and Georgia and our tissue bank. These are the areas that are in need of EMR Access at our partner hospitals. The EMR landscape for the OPOs I support are vastly different. For example, LifeLink of Georgia has approximately 10 major hospital systems that have 3 or more hospitals within it. LifeLink of Florida has 6 major hospital systems, which comprises of 90% of the donor service area hospitals. Both settings have their advantages and disadvantages. Not all hospital systems are made equal in terms of how EMR access is granted and maintained. Prior to my role being established, there were variable practices among the two OPOs in obtaining EMR access. LifeLink of Florida had a multidisciplinary team that created internal processes to obtain EMR access. This team also created internal resources that ensured the access was maintained by the clinical team. However, LifeLink of Georgia utilized the hospital development team to obtain and maintain users' access. LifeLink identified the need for operational alignment and recognized an opportunity for a new role within the organization to be developed. My position was established in Q1 of 2019. In my role as EMR specialist, I support the establishment, the obtaining, and maintaining of EMR access for LifeLink of Florida, LifeLink of Georgia, as well as the LifeLink Tissue Bank. So I found this quote from the Harvard Business Journal online. I thought it was very relevant to our discussion today and for you to think about when starting, restarting, or adjusting your EMR plans. A good strategy provides a clear roadmap consisting of a set of guiding principles or rules that defines the actions people in the business should take and not take, and the things that they should prioritize and not prioritize to achieve the desired goals. Before your organization gets started or continues to advance the process for obtaining EMR access, there are some items that should be reviewed. Has your organization created a strategy on how to obtain access? What are your organization's access needs? Who needs access? Does your organization have organ procurement, tissue procurement, a QA department? What level of access are you wanting or needing? After LifeLink created the role of the EMR specialist, we had several internal meetings to discuss our roadmap for access. That included not just where we were, but where we have been, what worked and what did not. We also decided on the goals that we wanted to achieve and what our priorities are. Our EMR strategic planning meetings included our hospital development leadership, our organ recovery leadership, quality leadership, and tissue recovery leadership. Laying the foundation to your EMR program might be the most important part of the internal process to ensure all stakeholders are on the same page. This process was discussed more with LifeLink of Georgia versus LifeLink of Florida, because access had already been established at many hospitals in Florida. When my role was established, collectively, we decided to create a systematic approach to what our EMR process looked like. How are we going to ensure all end users' priorities were thought about? As you can see on the screen, here are some of our objectives that we established on the most basic level. Which hospitals were we going to focus on? Who should be receiving access? And what type of access are we going to look to obtain? This also created a way to track what the EMR position was going to do. This had also been helpful in reporting progress updates to the OPO leadership. We separated the process for obtaining EMR access for our organ staff and our tissue staff. This was due to the different priority hospitals for each service line. Within each objective, we created key results to ensure we could obtain each objective. Example, organ, the priority of hospitals to obtain EMR access. Our key results were to review 80% of our donor hospital level of access, define where and what type of access has been granted, establish priority for obtaining access. The EMR specialist was to acquire management from any hospital development liaison of existing access, gain EMR access where access had not been unestablished based off of priority. Here is an example to illustrate that if you do have two different recovery programs, you might have a different level of priority. At LifeLink of Georgia, we have an organ recovery and a tissue recovery program. We were able to determine what we needed in regards to access before we talked to any of our hospital partners. We reviewed each hospital and system to determine who within our organization needed that level of access. From there, we were able to determine what type of access and for how many people we were asking for, all before we went to the hospital to discuss. Now the question is, how and who do we approach at the hospitals? This is where your relationships with your donation champions come into play. They might not be the ones who grant access or approve access, but they are your inside champion to advocate for the need within their organization. If you start at the bottom of your main day-to-day connections, you will eventually find your EMR key champions or contact to move the needle in obtaining EMR access. For example, at a smaller hospital in Georgia, the director of critical care knows we need access. They will start to assist in the communication with the director of IT or the clinical informatics or patient care services contact. The HD liaison would then put me in touch with the director of critical care, who would then give me the contact information for the director of IT. The director of IT has never heard of LifeLink before, let alone what we need to accomplish within their hospital. Some hospitals will take trial and error until you get to the right person. However, start at the bottom and ask for the top. You will land with someone in the middle. More often than not, I've had to have more fundamental hospital development conversations with my newfound EMR champions rather than explaining the level of EMR access my organization needed. If you explain the why, and not just we, XYZ organization, need your access to your hospital colleagues usually will help in whatever way they can, if they know the why. Some of the titles that I have had success in obtaining access are IS Operations and Account Security, Access Management Analyst, Director of Clinical Informatics, Front-End Support Analyst, Financial Systems Analyst, IT Business Applications Analyst, Systems Administrator Information Technology, Director of Critical Care Services, Director of HIM, and Clinical Application Analyst. Once we established the who, the what, and the where, we realized we needed to put more systems and practices into place. We did this to ensure that we were setting up the program for success as well as success for our staff. We streamlined older processes and created a few different materials, resources, and practices to better enhance our program. This was our corporate social responsibility to protect our hospital systems just as much as we protect our own. LifeLink created an EMR document retention system. Only the EMR specialist and direct directors have access to this database since sensitive information, signatures, social security numbers are located within this folder. Each hospital or system has a place where documents are held: blank forms, completed forms, job aids, activation emails from hospitals, and other various items that need safekeeping that just can't be located in my inbox. As an organization, we also determined that we needed a formal EMR policy. Yes, it was great we were having our staff sign all of the forms and policies the hospitals required, but what about the standards we hold our staff to as well? Within this more formal EMR policy, we touched on all parties involved and their responsibilities. This included an internal partnership with human resources, corporate compliance, and the end users managers. This was also a great topic to bring up with my newfound IT contacts, letting them know that we are in this together, assuring them that their systems will be safeguarded by our staff. This point is very well received by the contacts that I work with in the hospitals. Consider this to be an olive branch when asking for something the hospital does not want to give up freely. As an organization, we also determined that we needed to communicate formally with our employees as to what would be required of them for us to obtain EMR access. We developed an internal document with the assistance of our HR department, the LifeLink Authorization to Release Information document. This is the LifeLink way of letting employees know we will be providing their information to hospitals in order to obtain EMR access for their job. As you can see on the bottom of your screen, there is a statement to our employees. LifeLink provides identity theft protection as an additional benefit to staff that require EMR access for their job duties. In this role, I receive employee information via email from HR on a weekly basis. This is to ensure information does not get transmitted through multiple channels. When information is emailed to hospitals to obtain EMR access, they are sent via our secure email practices. After we created the EMR policy and the LifeLink authorization to release information, we thought we needed to do something for our staff to sign annually. That led to the creation of an additional internal confidentiality agreement. We call this our Partner Hospital User Confidentiality Agreement. This provided the framework for staff to know how, when, and where to use hospital-acquired EMR access. This serves as a reminder for all employees that we are taking EMR access seriously. What you see is a few line items that are a part of our two-page document for our employees to sign. Now, just because LifeLink has great relationships with donation champions and/or IT directors does not mean everything has been easy. There has been and will always be roadblocks. However, from our experience, many can be solved with additional information and communication. We started putting together this communication up front to limit the back and forth of requirements. Some additional hospital requests or pushback has come in the form of background checks needing to be completed by the hospital on all employees requesting access, vaccination records supplied by the OPO for each employee requesting access, copies of driver's licenses, business associate agreements to be created and signed. LifeLink, as an organization, has developed materials to address these issues on the front end. The most helpful resource for obtaining access is the staff attestation letter. In the letter, we cover the most common requests when obtaining EMR access for our staff. This letter can be then utilized for any and all hospital systems. We have used this letter most often with large hospital systems that require validation that LifeLink is completing the necessary credentialing for staff. Once this letter is sent, additional requests for the most part discontinue. The best piece of advice I can offer is to make sure you are talking to the right person that can make decisions on higher level requirements. Additionally, LifeLink does not allow hospitals to take a copy of staff's driver's license. If identity needs to be verified, LifeLink are only to show their LifeLink issued ID badge. So this is what our structure looks like today. You can see we have included HR, corporate compliance, and legal into our processes. This is to ensure that we are following internal and external protocols properly. We now have a streamlined approach with centralized communication, allowing the OPOs to achieve operational alignment in the EMR process. The single best internal resource that LifeLink has created is the monthly remote access check-in process. This tool was developed by LifeLink of Florida and is now used by both OPOs. On the screen is the current form that LifeLink of Georgia is using. This is a fillable PDF that is completed by staff on a monthly basis. It contains all of the information needed to remotely log into each hospital system where we have established access. Staff electronically initial the form to verify that their access is current and functioning. If staff have an issue with their login, they are first directed to the hospital help desk. If the issue cannot be resolved by the hospital help desk, then the staff will contact myself. Initially, the staff felt overwhelmed by this process. However, now that they go to the hospital for a referral, there is no longer a question, will my access work today? Here are some additional items that are on the horizon for LifeLink and our EMR program. LifeLink is just starting out on the EMR journey. There are many more sites to see along the way in creating a more efficient, safe, and productive work environment to carry out our mission to save and heal lives through transplantation. Thank you.
All right. Thank you, Elle, for that. That is, if you all didn't catch a couple of those slides there, come back to the set after the slide set after it is put on the website. There's that attestation form. That is a really, really good idea, as well as that monthly EMR access form. Already knowing that was coming, I already sent it to our staff saying, hey, this is something that we need to do. So some great insights there. I'm going to go down a little different path. Again, this is Robbie Glazner from Arizona. And so we know you all are from all over the place, all over the country, but we wanted to bring you sunshine today. So we have LifeLink from Florida and Georgia. It is 86 degrees there today, and it is 87 degrees in Arizona today. So if you're freezing up in the Midwest, I apologize for rubbing it in, kind of. But let's go ahead and go through and talk about EMR a little bit. We've been on this path a while, and so we've started with gaining hospital by hospital, system by system back in 2012, 2013, working through a lot of the things that we've had to figure out as an industry, such as even doing making sure it's in the contract or having a contract, a hospital agreement addendum to deal with EMR. But what I'd like to do is talk a little bit about where we came from. So just, again, this is Donor Network of Arizona. We are one of those that is a full spectrum OPO. So we're an organ procurement organization, tissue bank, ocular recovery, and distribution. We are the steward of the registry for Arizona, and we also have an HLA laboratory. But we've had a lot of growth, and with that, there's always a lot of challenges, new staff, more staff. As you can see, just in 5 years, we've grown 102% in the number of organ donors, from 158 to a projected of 319 as of yesterday at least, and even on the tissue side as well with 53% growth. And so with growth and having the entire state also builds in a lot of challenges. We have 7.1 million people here, but we only have 15 counties. If you go to some place like Minnesota that has 6 million counties, you have a lot more to deal with there. And I wanted to bring this up. We have the weirdest law out there. There's no camel hunting in Arizona. So I don't know why we don't have camels, but apparently before the Civil War we had camels. The Army was testing out camels in the Arizona desert, and then they didn't work, so they just let them go loose. But anyway, now you're going to go look up on your computer what your weirdest law is. I do want to bring up that with our hospitals, we have 120 hospitals and 13 trauma centers. So that's a lot of trauma centers, and based out of Tucson, based out of Arizona, a lot of competition for trauma and feeling those effects all the time. But a lot of trauma centers for 7.1 million people. With these hospitals, these 120 hospitals, as of and I haven't looked at it here for this year yet, but as of the end of 2018, 98% of our organ donors were in hospitals where we have EMR access. That's 98% of our projected 319, I guess that would be. And on the tissue side, it's 89% have EMR access. Now that's just EMR access. Remote EMR access, it goes down to about 94% of our organ donors in the hospitals with EMR access. And so a lot of strides have been made, but there's a lot of things that we need to continue to work on and to focus on. And so with this presentation, we didn't want to duplicate what we were talking about. I'm going to focus on these 4 pieces. As we've been thinking about navigating access to EMR and having strategies for success, I want to briefly look over structuring for EMR success, communicating for EMR success, managing tools, as well as looking ahead for EMR success. And so part of this is systematic. Part of it is just looking at tools, but hopefully you'll find a few things in this slide set that will help you or at least get you thinking about next steps in your own space. So let's look at structuring for EMR access. As we think about structure, we also have to think about part of that as strategy and continuity. So OPO EMR continuity, it is important that we have a continuity of EMR access, electronic medical records. And so from a database to be able to assess what are the ongoing medical record needs is one of the things that our partners at LifeLink in Florida and Georgia there really focused in this presentation, showing us those policies and the process behind them. Having Centerpoint in training, a Centerpoint for your EMR, I'm going to talk about that a little bit more, but also strategic planning for EMR. Not just reactionary. We tend to be reactionary. We don't have something here, so we react to it as opposed to proactively thinking, where's the industry going? And so how do we build this into the structure? Now, this is a very busy slide. We're not supposed to have busy slides, but hopefully this can be a resource that explains our model. We have, if you see on your left-hand side, just start on your left-hand side, and those will represent our internal employees, our internal EMR stakeholders. And so at the step of EMR onboarding and EMR removal, when someone is no longer employed here or changes job functions, as well as just dealing with EMR maintenance issues. Those 3 up in there, they go down different paths. And so we don't have just one person that deals with EMR. We have one person that is that administrates it among many other things, but they administrate the EMR. And then we have an EMR specialist that does other things. I'll introduce you to them here in a moment on the slide set. But it's a team environment. It's making sure that we have a continuity, as you saw in the previous slide. So when there are staff that need to be onboarded, there is a path, and it goes to the administrator. When those staff need to be removed, it goes to that administrator. And if you follow the blue line there, the aqua line, they go to the administrator, and the administrator deals with some of those hospital systems herself. And then with systems that require manual system entry, meaning a hospital requires that we fax something or that we email something, those hospitals then updates go to the EMR specialist, and the EMR specialist is doing the manual entry into those systems or sending of faxes. Because many times we need EMR access removed right away, and our commitment is to react quickly. But as pointed out previously, the direct system entry, many of the systems, we actually have accounts set up in there where we can go in and we can update the hospital system. For gaining access, it still would require someone to sign off on us putting in the ticket and managing that ticket. But we have direct portal access into the hospital system to add people into the queue to get access. And so that's what the hospital administrator would do. But then we know that we have ongoing issues, and that's where that red line, you can see the red line and the blue line make purple. I actually looked it up on the Google, okay, and so that's why it's purple. Both deal with both things, both of our specialists and our administrator. But Whenever staff have issue, they might bring it up, they might send an email, but we have a ticketing system that's set up, and the tickets are created and managed. If someone were to email, they can email our EMR ticket at dnaz.org, and they would be able to set up a new ticket would be automatically created and queued and dealt with. And so both of our entire team can deal with those things. If you look at the bottom of the slide, what about new EMR access? Well, while our team is working, again, this is just one portion of their job. It's not the entirety of their job. While they're working through those things, getting new EMR access or really re-engaging old systems in new ways, that's the responsibility of the OPO management, and that's myself right now. It might actually be our Vice President of Communications, Sarah Pace-Jones, or our Hospital Development Director, and there might be others involved, but we're trying to set up new hospital access. And so as we want to develop these hospital relationships, and as you'll see other key stakeholders, those are things that I'm actively working through. One system right now, I reformatted their application form to align with what we considered best practices, and they're pushing that through their hospital system for approval through their access management and their IT department. And that's the kind of relationship that we need to have at a higher level. So hitting it from this kind of a model where we have multiple internal stakeholders being dealt with by our EMR team, being able to deal with external stakeholders in a very systematic way based upon if they're direct system entry or manual system entry, as well as new development has been key to being able to make strides in EMR. Again, I'm sorry for the busy slide. I hope that kind of explains a little bit of how we deal with these things from a systematic way. How do we structure for success? And structure is important. And so with that, I wanted to highlight that most of the work that is done by them. And I'm here giving the presentation, but they should get the credit. They do a lot of work. And alongside our best, we have the best hospital development team on the planet. And I say that unashamedly. So much is done by our hospital development team. I would encourage the OPOs, at least on the phone, to consider how you utilize your hospital development team for gaining EMR access. Going on to communicating for EMR success, I wanted to give you many tools, many points that you can come back to and maybe draw upon at a later time about ways that it's best to communicate to hospital systems. You see hospitals, and we use this actually, and you'll see it on another slide, but we use this model where we're working, because we're not part of the healthcare team, we're not taking care of live patients. We're not part of the healthcare team. We're one of the specialists that comes alongside the healthcare team to perform a very needed aspect of caring for someone else's health through transplantation. And so we're there working with families, and we're working with deceased donors, and we're following along according to our agreements. But we're often grouped as business associates, and so understanding that we're brought in as this alongside the hospital. When that referral is made, we are part of a broader team, and so helping explain that there's different ways to do that. And one is to even break out and be able to show that and use in different models and modeling how we are already getting medical records, if you would say verbal copies at time of referral. We're getting at referral assessment when we call back at shift, when we go on site and we talk to the nurse, when we talk to the physician or the palliative care physician. And then obviously at the donor case, but even at time of death record after the cardiac time of death, the death referral for tissue donation, we're getting aspects of that medical record, maybe not a permanent copy, but we are getting a verbal copy of that patient's health information. And this is, so it's not unnormative to be able to request or want access to medical records. It's part of the process. And so how do we communicate that? Here's a couple snippets of, these are sheets that we'll hand out at conventions or Health Information Management Association meetings, things of that nature that talk about what that partnership is and how HIPAA, how we fit within HIPAA and what that partnership between Donor Network of Arizona and hospitals looks like. We also have one here that's based upon, really focused on hospital EMR, and those 4 different paths, we would say, the organ donation referral, the tissue donation referral, the compliance referral review, and the recovery quality assurance. So each of those are 4 different uses for EMR, and they're needed at 4 different stages, and they need to view, many times, different things in the medical records. So that really leads us to thinking about what do we need. So we need to assess what kind of access is needed, what method, is it just on-site, is it remote, what information and what are the hurdles. And so I want to focus here on this next slide that has been really helpful with systems on the information that is accessed. Once you get past that, okay, yeah, this is something that you should have, the question then is, well, what parts of the medical record do you need? And so what we did is we just mapped it out. We said, well, for these 4 different paths, these are the different things that we need down those 4 different paths. Well, if you look at this, that's pretty comprehensive. That basically means the entirety of the medical record. We need the diagnostic testing. We need the flow sheets. We need pathology. We'll need the physician's orders. And there's so many of these things, tox screens. And so communicating that we need these things for these 4 different paths has helped mitigate those questions of, well, we want to make sure that you only have access to this part of the medical record, and we haven't had to circumvent any part of the medical record yet. So it's also in communicating to them, to hospitals and to our partners, that we have a process. I really liked LifeLink's process. They've really thought it out very well. I'm going to take a lot of that back to our OPO. But the initial access, maintaining it, removing it, how are people notified, and having hospitals understand that you have a system, that we consider this a high priority, communicating to them these things through forms such as that LifeLink used, or through some of the modeling that we would use. It is important that they understand that this isn't haphazard. This isn't, we're just giving someone access and we'll figure out in a year if they don't need it anymore, that you have a process. And so communicating is very important for success in EMR. Also, dealing with tools. So I'm going to share one thing that we have that we're using, and there's OPOs out there that are doing really good work in this space. I'm sharing what we are using. What we do is an EMR Centerpoint on SharePoint, and so this is a landing page for EMR. It deals with, you can see there on the left-hand side, everything from copies of applications, documents, system information, user guides, training. We're going to look at a few of those things, but then the direct links and the numbers, as well as a link to the web ticket. If they're not in the web ticket environment, they can click on that and go over and access that. But it's a one-stop shop. If you have a question, there's frequently asked questions. We'll see. But the first part is the EMR training. This is something that we have put into place to help mitigate questions about, well, we need to train your staff. So bring all your staff in for 8 days, and we're going to train them on Epic. When we explain that our coordinators that have EMR Access have training in systems, but primarily they have training at a 101 level. That is, that they know how to manage patient information, they understand policies, they understand security, sharing of passwords, all of those type of things. And then they're also introduced to each system because we have access into 98% of organ donor hospitals. So we know Epic, we know Cerner, we know MedTech, and we can navigate those. So knowing that we're at least dealing with training in some regard, even if it's not 8 days of training, for us has worked with our hospital systems. We've not been asked. We had one hospital initially, but then they've dropped the requirement for any kind of external training beyond what the OPO ourselves provides. And so that is there on the SharePoint as well. And it's gone through at 30 days. When people sign up for their application, they sign their applications, We do an OIG background check every month on every EMR user, and we keep a record of that. So we're doing that OIG, Office of Inspector General, healthcare fraud background check. You can do manually. It doesn't cost you anything at all. You can just go to the website and run it yourself. And so we do that. So at 30 days, we train. We have application side. Depending if it's a new organ recovery coordinator, we might have to do it earlier. But there's obviously many questions that happen after that. And so how do we deal with those questions? Well, frequently asked questions section. Here are some of them and the most recent. Also, how do people know what kind of access that they have? And so I protected the names there, obviously, but you can see that this is a tracking. This is a database, Excel-based, and again, some OPOs have some nice systems out there, but it's Excel-based where it keeps a track of who has access to what, if applications are pending, if they're submitted, or if they have been approved. And so, so really a Centerpoint utilizing our tools. One thing I wanted to finish our time this afternoon with is looking ahead. If we're, I mentioned it before, but if we're constantly reacting, we're not looking ahead to where the industry is going. Maybe you're familiar with high-tech and 2009 Act of Congress, and we all know HIPAA, but there's a lot of movement that is happening in the EMR, EHS space in regards to our access to records and interoperability. Here's a slide that I made a number of years ago that's based upon a roadmap that the Office of the ONC of High Tech, the Office of the National Coordinator. This is the office in the government that is overseeing all this hospital systems, talking to hospital systems, and health information exchange, and how we need to be able to get records from one place to the other. And so this is the mandate, and billions now have been spent on this. And so ultimately ending in 2024, well, you can see the initiative there is through 2020 is to establish a framework for nationwide health IT interoperability, to implement some of this, and to incentivize hospitals and enhance that, and then to add clarity on what does it mean to be secure. And so this is something that the hospital is aware of. This is something they're being incented. Many of these hospitals, probably most of them, have received incentives to be able to do interoperability and to allow the systems to talk. And so we know this. This is planned out. This is a roadmap. So what are we doing to be able to get on that roadmap, to be able to have the access in the years ahead that is not hospital specific maybe? So I have 3 or 4 items here that I wanted to bring to you to get you to think about maybe what lies ahead for us. So I ask you, what is your relationship with your state health information exchange? Maybe you're asking, what is a health information exchange? Well, this is a place where hospitals send their data. In Arizona, we have a relationship, and actually we had access through last year, and then a law, some nuanced law was passed that had unintended consequences. So we had to get that law changed, and we did. We worked with the Health Information Exchange, our attorneys with their attorneys. The law was changed because they didn't realize that it had this effect. It was passed, House, Senate, the state, and now we're getting our access back. So we have access to this place where hospitals send in, 80% of them send in real time their hospital aspects of their hospital medical record. These, you might say, well, we've looked into that before. Well, if you looked into that further away than a year ago or a year and a half ago, it is not the same type of health information exchange. They have grown in their sophistication exponentially. Arizona is part of a team of many, and it's just expanding. It's not simply the hospitals talking to one another, talking to this health information exchange, sending them their medical record information. It's the exchanges themselves from one state to the other being interoperative. So if I was in Kansas and I hit the ER in Kansas, it would hit the health information exchange in Kansas, and it would automatically then hit the health information exchange in Arizona, and it would send a notification to my primary care physician. So this is the kind of sophistication that is being built out, and over the next several years, I think will continue to grow with the initiative from the ONC. So think about making those steps, reaching out to your health information exchange. Do you have a presence in your state HEMA meeting, so the Health Information Management Association? So I've spoken on organ and tissue donation medical records at the HIMSS Association. Being able to have that inroad to the people that are stewards of the information, the health information. And so get connected with them. Be a part of, I've been a member for 5 years of a HEMA, and stay connected and understand what they have to offer and stay part of the dialogue. Also, do you have a relationship with your state Department of Vitals? So we have EMR into the Department of Vitals. Now it's limited. We only have a handful, and we're actually signing a new agreement as of this month. But where we can go in and search for causes of death into the Department of Vitals for the state of Arizona. So having a relationship with your state Department of Vitals to be able to release your tissue, your ocular tissue in a timely way, those type of things. I would encourage you to, again, looking ahead, think outside the box of just going to the hospital. There's a comprehensive view of medical records as it affects organ and tissue donation. And then what about your own EMR? We use iTransplant. I don't know what you use. Ours is through Transplant Connect called iTransplant. You might use a different vendor, and without listing them all. But what role might your EMR have with the donor medical record access and transmission? Could you not have your system talk to their system? And I know Transplant Connect has been working on that, where that EMR access, that upload of information, a lot of the information is uploaded. And what would that look like in 5 years in your state if you were to go down that path? So here are some ideas, some thoughts to be able to hopefully help us think about what is next, because to navigate this access to EMR and to be successful, and we need to think through the structuring, the communicating for success, managing the tools, and looking ahead. And I know it's hard. I know it's difficult. You can see navigating EMR access, it might seem like it doesn't pay off, but results will come with a strategy and persistence. Like this quote, I worked out for an hour, and all I lost was 60 minutes. Sometimes you feel that way, and you're like, wow, I thought we made so much headway. We've gone through with one system in our state a security assessment with a comprehensive review of how we handle security, and from passwords to number of sign-ons to our server to third-party vendors, all of that. And it's taken us 9 months to really just work through it, but good results. And so with strategy and persistence does come a lot of benefit. So with that, I will hand it off. Thank you again for your time and consideration.
Thank you so much, Robbie.
And sorry, Nikki.
I didn't mean to interrupt. You carry on.
Oh, no worries. Before we go ahead and open the floor up for questions, I just would like to remind everyone that if you do have any questions for either of our presenters, please be sure to submit them using the chat feature. Just as a reminder, that's going to be located at the bottom left-hand corner of your screen. Additionally, during the Q&A session, I'm going to have this poll up. So for those of you that are listening in a group, if you could please complete this poll and just let us know how many people are participating in your group, that would be greatly appreciated. So with that being said, I'll go ahead and turn it back to Nikki to go ahead and moderate your questions. Thank you.
Perfect. Thank you so much. While we wait to see if anybody has any questions, Elle, would you mind commenting on, with regards to your attestation letter, did you receive any pushback from the staff with regards to that? If you did, how did you navigate through that?
So we didn't get any pushback. Yes, can you hear me?
Yes.
Okay. So we didn't get any pushback from our staff, so to speak, on the staff attestation letter. We developed it internally with our leadership team. It went back and forth a couple different drafts, including what the content was going to be. for that letter, and once that was approved, there hasn't been any pushback from the hospitals as to what the content includes.
Perfect. Thank you so much. And it looks like Laura has a question. How did your organization navigate providing vaccination information to the hospitals?
So again, I think that's directed towards me. So what we did, I think can I go back to that slide really quick? Is there a way?
Yes, absolutely.
Okay. Ooh, didn't let me. Okay, maybe I have to go this way. So we didn't, from what we did, we don't require a flu shot. So we just put what our immunization record requirements are. So as you can see on the screen, it's the tuberculosis and hepatitis B. Informed consent or refusal. So this is the only document we show our hospitals. We don't give them anything else as to what our employment screening results are, including vaccination records. It just says that they have been done and we have copies. And again, there's a blurb at the bottom that says if you have any additional questions, please contact Human Resources. To my knowledge, Human Resources has not been contacted by any hospitals asking for additional verification.
Perfect. Thank you so much. Roxanne has a question for Robbie. Could you repeat what law you had changed and why?
Sure. Yeah. So there was a law that had that was designed in the state of Arizona. The law was designed to protect psychiatric evaluations, and so those are obviously not needed for organ donation. We don't need those evaluations or for tissue donations. But in the health information exchange, all of that data was intermixed, so they couldn't separate it out. So since this law protected that type of information from even from an unconsented primary care physician, that was removed. We were not allowed to have access anymore into the health information exchange at all because they couldn't separate it out. And so they worked on separating it out, but we also worked on changing the law. And so between our attorneys and working with the state legislature, because it was just an unintended consequences. It basically said, unless there was consent for this, in no right are you allowed to be able to see this. But then the anatomical gift law said unless otherwise excluded. And so it was otherwise excluded and we couldn't get out of it. So we worked through it and partnered and it worked out.
Perfect, thank you. A question from Melissa. Our biggest challenge is making sure our staff maintain the EMR access. What suggestions might you have?
So this is Elle. I can answer part of that as well. So I showed one of the examples that both LifeLink of Florida and LifeLink of Georgia utilize, which is that remote check-in form that staff are to complete monthly. But really it starts from the top down. So we have monthly leadership meetings with both OPOs that the staff, it's made important, that's a very important piece and part of the process to ensure that staff are doing that check-in form on a monthly basis to make sure that their access is maintained. In some instances, there's like a random audit that can be completed by the management team, who has completed it and who has not. For example, in LifeLink of Florida, the manager verifies each month that each staff member has completed it. If they haven't, they stay behind in their staff meeting to have that completed. So it's really important it comes down from the management level and not necessarily coming from me that it's a requirement. It's more top level. And
I will, from Arizona's side, yeah, LifeLink has done, I mentioned it before, but I think that form is a really great idea. I was even thinking about here maybe even doing like an electronic survey type of form, so they could do it through a survey function. And that made me think that we do have on a weekly basis, our data analyst goes and identifies all of our potential organ donors, and they get categorized, and anyone that had a family conversation or has missed opportunity, those type of things are reviewed in a Wednesday meeting through results of a survey. We send surveys to all of our staff that are on the case as well as the hospital staff, and then we bring them together in a report. One of those questions for our internal staff is, were there any EMR challenges while on this case? If it's yes, it automatically sends an email notification to our ticketing system, but it's also reviewed by all the supervisors, managers, directors, and vice presidents during that meeting. And so there's a little bit of accountability, like in a practical way, like from week to week. If there are EMR issues and it's the same person, then all the management is seeing it in that kind of a framework.
Perfect. It sounds like regularity and constant check-ins from the top down is really the take-home message. Mm. Perfect. Thank you so much. It doesn't look like we have any more questions just at the moment.
All right. Well, that being said, thank you, Nikki. I'd like to once again extend a sincere thanks to Elle and Robbie for joining us today to share your expertise and your personal experiences with obtaining EMR access and kind of navigating those various challenges. So thank you so much for joining us today. And additionally, thank you to Nikki for also taking the time to join us to facilitate today's discussion. To all of our participants, as always, we thank you for your time, and we hope you enjoy the rest of your day. Take care.